complex time. So let me just start, I guess, the basics of what our team does. So Addictions Medicine Consult Service is the name of the team. There are 4 people on the team. There's an addiction medicine physician. Many of our physicians also work in community, AVI, True Beginnings. Some of them work at the UPCC, like at the Medical Arts building. There's a nurse educator, myself. We have a social worker named Chantel. We have an addictions worker named Jenny. A lot of our physicians, like I say, work in as community OAT prescribers. So our main medical team is Dr. Wilder, who works at AVI, Dr. Jern, that works at True Beginnings, a couple folks that work in some treatment centers, Dr. Barron, who also works down at Medical Arts here. So our doctors are fantastic, and they're well versed in how to support people when they come in the hospital to A, be safe and be comfortable.
Keep people calm, right? You keep people calm.
That's a big part of it. When people, you know, our team recognizes that when people come into hospital, they come in varying stages of change. There's different stages of change, and some people come into hospital because they don't want to use substances anymore and they need help stopping. And some people come into hospital because they've had something happen to them, they've fallen, they've had an injury, an assault, or an infection, and they need medical attention, but they're not quite at that place where they're going to stop using substances.
Right?
Yeah, absolutely. And so we respect that. Like we're very patient centered. So we're not telling our patients, look, you need to stop using drugs and you'll be better. We're recognizing that like different people need different things depending on who they are, what they've experienced in their life, what they're using, what their goals are, what their recovery capital is, what kind of like what their assets are. Are they housed? Are they healthy? Do they have diagnosis? And this is, I think, something generally people in mental health substance use excel at, is developing good therapeutic relationships, like realizing that first and foremost, people who use substances are human beings. We have value, we deserve dignity and respect and kindness.
You definitely align with Nandu's purposes.
Yeah, absolutely, I think so. So I think, you know, our team does a lot of good work, and like I say, you know, when people come into the hospital, if they're identified as having as using substances, regardless of whether they're identified of having substance use disorder or not, and not everyone that uses substances has a substance use disorder. Not everyone that has a chemical dependency has a substance use disorder. So there's this kind of like big spectrum of substance use between like beneficial, recreational, all the way over to like chronic and problematic. And we realize that like different people need and use substances for different reasons, you know. But like, for example, if someone, say 75-year-old grandfather has cancer and he's getting hydromorphone every day for his cancer, maybe some methadone for pain, 75-year-old grandpa is chemically dependent on opioids. And he needs those opioids or else he's getting sick.
More pain.
And he's getting more pain. But somehow we look at that differently than someone who uses opioids and is chemically dependent on opioids who is on the street, or even if they're not on the street, but he uses them because they need to, because they have a dependency, right?
There's definitely a different look at people who are on the streets, because a lot of people that are on the streets refuse to go to the hospital to get help because of that.
Absolutely.
Yeah.
So, I mean, I see my job as, I mean, I have a lot of different hats that I wear, and I also work on outreach, and I also work for CORE, doing crisis stuff, and I also work.
When you refer to those UPC and the core and stuff, can you then say what they are?
Oh yeah, UPCC.
You
I
don't
didn't
mind.
know it. It's like a urgent primary care
Okay.
center. So it's Medical Arts, like the only walk-in clinic in town.
one down
CORE. What's that?
The one down at the mall.
Medical Arts. So it's right across from London Drugs.
Yeah.
When I say CORE, that's community outreach response. So that's kind of like crisis response team, homelessness outreach support team. You'll see us walking around with orange jackets, giving out harm reduction supplies and doing wound care and making sure people have socks or connected in their other resources.
You must stop at the LPS because I think I recognize you from
Yeah,
the LPS.
yeah. I also work for SUSO, which is Substance Use Services Outreach, and we're doing kind of outreach with regards to substance use and connecting people to services. If they want to go to treatment, we're supporting people with that. If they're looking to try and access housing, we're trying to help with that. It's tough. Harm reduction, like providing people with harm reduction supports as well. And I've also done some work with PCO, which is Primary Care Outreach Team, and that's the van that goes around with the doctor and a nurse and doing wound care and social work stuff. So there's lots of like teams and community mental health substance use. Where I work predominantly is addictions medicine, and that's in the hospital. So that's part of like acute.
You don't sleep, do you?
Who do we
Not-
ask?
He doesn't have a life.
Not much.
No.
Who do we ask
Doesn't have a
for?
home life.
I'll get to that because that's kind of changing.
That's the big thing, right?
Yeah, that's a good question. I'm gonna get to that because like we've had some changes recently, and I wanna talk about those.
Do you want to write on anything? Like,
I could
Yeah.
try, but you wouldn't be able to read it
okay, I'll just
because
take
my
notes.
writing
Is that
is
okay?
like
Yeah.
I
pretty
can write
terrible.
stuff too on the board if you want.
Okay. Well, I can write
So,
it.
so when people come
You
into
can
the
erase the
hospital,
other
they come to emergency first.
The erasers are good.
When
If they go.
if they go to emergency, and you're right, a lot of people don't come to hospital because of fear that you're not going to get treated well, you're going to be met with stigma, you're not going to get your withdrawal needs met, you're going to have to wait for hours and hours and hours before getting meds. Okay. So I'm completely aware that there are challenges for people who come to hospital and for them to feel safe. And we want everyone to feel like they will come to hospital and get their needs met and be safe. But we also recognize that doesn't happen a lot of the time. You know, I recognize we were talking about this on the break that like, you know, there are decades. There were decades where like First Nations individuals, Indigenous folks were met with institutionalized racism when they came to hospital.
Somebody died on the front steps of the emergency. That's why they have an Aboriginal liaison nurse now.
Right.
Yeah.
And it sucks that like things like that have to happen before action takes place. But for the longest time, Indigenous folks weren't welcome in hospitals. They weren't treated well. And I think, you know, over the last 10, 20 years, our society has started to kind of realize like we need to do better, we must do better, and have taken great steps to kind of to make institutions like healthcare, like policing, like the military safer for people who are Indigenous, safer for women. And I think a lot of that institutionalized racism, you know, people, you know, are taking great steps to kind of start to make hospitals safer for those people. But there's also a lot of institutionalized stigma. You know, this idea that like if you use drugs, you know, hospital is not the place for you. And I think
Because it hasn't been.
I think, you know, definitely, I think things are changing really quickly, but I think we've taken a lot of really good steps in healthcare, especially in acute care, to start to change things. Now, you know, I think about like 10 years ago, we didn't have an addictions medicine team.
5 years
You
ago.
know, like when we started at the addictions medicine team 4 years ago-ish, maybe 4.5, and it was one doctor. Now we have a 4-person team with 5 doctors. We work Monday to Friday, 8 till 4, which is great, but
What happens at
what
night?
happens at nighttime, what happens on the weekend? So now we're like expanding to be 7 days a week. So like things are improving in healthcare with regards to like addictions medicine, but things move really slowly. And that's frustrating for me. It's frustrating for people who require this kind of service. It's frustrating for society. One of the challenges we are facing is that like we got a whole bunch of crises all converging at the same time, right? So we've got this toxic drug crisis. We got like all sorts of junk in the drug supply. 7 people are dying a day in the province. many more overdosing, many are getting brain injuries and compartment syndrome and amputations, and all this chaos is happening because of the drug supply. But we've also got housing supply issues, homelessness issues. We've got a lack of social services. We had a pandemic which kind of fucked everything up and made people kind of pull away from some of the harm reduction things that were starting to work to get numbers down. We've also got a healthcare crisis. The pandemic put a lot of strain on the healthcare system. We've also got like an aging workforce and lots of short staffing and increasing patient loads. So more stress on the patient, on the nurses that are working. So we've got all these things that are all kind of affecting our ability. That's okay. To provide the kind of care that we know that people need, right? And it's made for a real complex challenge. You know, I often use this idea of a complex equation, just like one of those old math equations from algebra. And there are all sorts of variables, numbers and letters that go into that equation. And a lot of those variables we don't have control over in healthcare. I have no control over housing, the levels of housing. I have no control of how many shelter beds are available in the community. I have no control over how many staff we have right now because there's a wave of COVID going around, or everyone's burnt out, or everyone's off for disability. So, you know, there are so many things out of my control, including what's in the drug supply. And this is my argument for safer supply, which is like the sooner we can bring the drug supply into a regulated kind of forum, the more control we're going to have over the amount of people that are dropping dead and dying from the drug supply. And a big part of what we're doing in addictions medicine is we're competing with that illicit supply. If people have, say someone's got 100 receptors that need to get filled, the more our team can fill, the more of those receptors our team can fill, the better.
The brain receptors.
Yeah.
Yeah.
We get new ones all the time, and they build themselves.
The more of those receptors we can fill with our stuff, be that methadone, Cadian, Suboxone, hydromorphone, fentanyl, the better. Because the stuff that's out there on the street,
Mixture of
kill you.
It's mixed. there's benzodiazepines, there's tranquilizers, there's all sorts of other pharmaceutical meds, and there's all sorts of like new novel fentanyl analogs which are even more potent, which are unstudied. So we've got no control over this big kind of like unknown, which is like the unregulated drug supply.
I don't know what they put in it.
No, we don't. I mean, we're starting to learn just from our drug checking services that like we're starting to identify like, holy shit, there's new things coming every week.
I worked in a pill place in Kelowna. They never wiped the table when you put the new pills on.
I believe it.
They never did.
I believe it.
They just pour the pills on, and then you pills.
Yep.
I went to jail,
Yeah.
and I couldn't cold turkey, I could die. I got a shock to die, just like alcohol.
Yeah. I mean, it is.
That's a sort of a question. Do you have a liaison with with the local jail here?
Detox and
No, just for
Oh,
people
okay.
in jail. If there's ever a medical issue, do they go to Nanaimo Regional?
For medical issues, yeah, we've got
And then,
folks coming in to hospital from corrections all the time.
And does
They're actually really easy to identify because they're walking around the jail guard in
Yeah.
their reds, right?
Yeah. But do you guys, for people who are on methadone, is there a system within?
Yeah, so they've got like nurses and prescribers at the jail, is my understanding. And we have, like, we will liaise with them if we have a patient from the correctional center who's admitted to hospital. Most of the patients our teams are seeing are admitted to hospital. A lot of people who are coming through Emerge and are getting discharged will never make it to our team, and that's a gap. But if our physician gets a referral, whether it's someone who's in jail or not, you know, we will assess them, continue their medications, start them on medications, titrate them up on medications. And then when they go back to wherever they're going, whether it's jail or their community or the street, we will try and close that loop. So we will call the jail and say, hey, this is what we've done. We've increased them, we've stabilized them, we gave them a Sublocade injection. We will kind of close that loop with their community prescriber. So we will call down to AVI and say, hey, just so you know, we've started someone on this. This is what you need to continue.
And the Sublocade injection is Narcan
No,
and or
no.
what's in the